Welcome to this Clinical Experimental Allergy podcast, where we're going to discuss a really interesting piece of guidance from the British Society of Allergy and Clinical Immunology around the implementation of Palforzia peanut oral immunotherapy in the UK. And welcome to Tom Mars, who's lead author on this guidance, and is going to tell us a little bit about himself and the work. So, Tom, can you tell us a little bit about your background and what inspired you to develop this new BSACI guidance?
Hi there, thanks a lot, Bob. So I'm Tom Mars. I'm a researcher in London, UK. And I mean, basically over 20 years of working in paediatric allergy, it's been really clear that people have got different resources in different places and people have got different access to care according to where they pop up in the health system, in the national health system that we have here. And so it's quite opposed to all of these new developments. Allergy is an exciting field. There's lots coming along. Some of these are very translatable interventions to do with dietary protection from a young age. And some of them relate to new treatments and new medicines and new ways of using food. And I suppose that really is a stark contrast to what we see unfolding in terms of care pathways in the UK. We know that the European guidance, the American guidance, and Galen have all said that oral immunotherapy is the gold standard and important to offer for quality of life. And the challenge, therefore, is how on earth we can do that in a setting where we've got more constrained resources. So I really wanted to do this so that we could best support practice across England, to be able to say what is safe practice, what can we expect that is necessary in order to be able to advocate to get these changes, business cases approved, and to start to be able to offer this more widely. Because ultimately it should be a needs-based system that anywhere, wherever you are, if you have the conversations and the information to be able to access the treatment, you should in theory be able to get something like the treatment so that we're able to offer that to the family and children.
Great, thank you very much. And so what exactly did you do? How did you build consensus around guidance for Palforzia use?
Yeah, so we started off with workshops with children and their parents who had received peanut immunotherapy. And at this stage, it was in the middle of 2022. So we had literally only just had the notification from NICE that it was approved. So no one had had treatment on the NHS at that stage at all. So we were accessing families who had been research participants and they'd done not just Palforzia, but also other forms of peanut immunotherapy. And so we asked them age appropriately on their own, if they were old enough to have as young people, or in online workshops with their parents as well, to ask from those that had managed to get up to treatment and those who hadn't made it about their experiences. So we understood what they valued and what we should try and bring into being clinical practice. So from there, we designed some template guidance statements, which were initially drawn from that information. And then we took it forward to a voting panel. And the voting panel were equally split between those in specialist care and those in secondary care, so general district hospitals as well, who worked in paediatric allergy clinics. But we made sure that we had representation from nurses, from dietitians, from adult immunologists, from academic researchers, as well as paediatricians, to get a spread of what this might mean as in terms of implications for the whole of the healthcare patch. And so through a system of anonymized voting and then a workshop at the end to discuss some of the principles in a bit more detail to really get to what we felt as a group and define proper consensus on some thorny issues, then we came up with these statements of guidance.
Great. And what are the main recommendations that you made?
So the most important one really is to support healthcare professionals having balanced conversations about peanut immunotherapy. And access to the treatments is one thing, but anyone with the information and the guidance and the qualifications to have these conversations orientate about care for the child, most importantly, is really important to be able to level up and see whether people might be able to take a balanced view on whether or not it's right for their child, and whether the child or young person thinks that this is a good thing for them. So that's really important. Then, of course, there has to come a decision about, okay, so maybe if you are interested, these are the kind of options that are laid out for you. And of course, we put all this together, as I said, only when it had just been approved, and it doesn't reflect information on what is currently available or the current options that people are going through at the moment. So we also needed to make sure that it covers a suite of what the pathway should look like. So, of course, the eligibility criteria as outlined by the product guidance is important. We wanted to make sure that the majority of children would be offered food challenges, peanut challenges, as part of their diagnosis to be sure they have peanut allergy. It's important to control any other allergic diseases, particularly asthma, to make sure that it's a safe pathway through it. And we need to make sure that from a service point of view that there are at least 2 healthcare professionals who are nominated as leading the service, so that they don't go through quiet patches and leave, and that we can respond to parents' queries and families' queries within 72 hours.
Thank you. And were there any areas that were particularly controversial or caused a lot of discussion amongst the group?
Yeah, and I think this is where it became really interesting. About a quarter of the voting panel felt that the oral peanut challenges should be absolutely mandatory. They felt this because you had to be completely sure of absolute diagnosis, and it was a way of also going through the correct safety training with the family and the child themselves. The child gets to recognize their own symptoms of how they would present with a peanut allergic reaction, and all of that was a really important process. On the other hand, others felt that that would add to a challenge backlog, and that we were already potentially taking capacity away by offering any challenges or offering Palforzia, and that therefore that wasn't always necessary. And some people were concerned about whether or not in every case with high levels of sensitization and a clear history, that was always in a benefit in terms of safety. There were a few people who also felt that challenges were important from ascertaining thresholds. And this is quite important because all of the trials studying this treatment have enrolled children who either react to up to 100 or 300 milligrams of peanuts. So we know that it's very effective for those children for raising their threshold, right? But in terms of whether or not that can be effectively rolled out equitably for all of those as a treatment option with peanut allergy, well, we have to choose what is a reasonable battle for resources on behalf of these children as well. Some of them felt, the voting panel felt very clearly, that unless you could show they would react to less than the maintenance dose of the peanut immunotherapy, there was uncertain benefit. On the flip side, there's uncertainty in terms of how stable one's peanut threshold for no symptoms is in the long-term condition anyway. You know, we should ideally have studies to be able to spot which of the children whereby their threshold for tolerating peanut may drop and drop and drop, and so they become more sensitive to lower doses of peanut over time. We don't have that data, and we also know that thresholds are unstable. So, given illness or tiredness or other environmental factors, that it can mean that you end up with a fluctuation, and you may also have vulnerability to less of a threshold under 300 given a certain day. So that was quite a big topic of discussion and really needs more evidence. And then I suppose it was really about thinking for across the age groups. You know, it's licensed from 4 to 17 up to the 18th birthday. On the one hand, we need to involve young children as much as possible in that consent process. We've got to make sure that they're fully informed, and it's a long journey. I mean, the families all told us in the workshops they wouldn't have expected what it feels like to have the peanut reactions, to come in so many times. The families told us very clearly you have to put your lives on hold for 6 months because it changes with a regular dosing of peanuts at a certain time every day. You have to put aside the clubs and activities and families' commitments, and you have to really concentrate on the peanut updosing. And then as you get through to the older age group, the NHS is not great at managing care for young people as they become more independent, and specifically as they start crossing their 16th birthday, when it's not quite obvious that the footprint of paediatric care can reasonably afford all of those extra reasonable clinical concerns for more independent young people, and particularly as you get forward to 17 and 18. And that's particularly important when you're thinking about longer term daily dosing, converting onto real world peanut. And where do they go for queries afterwards? Would the GP handle it? Would the A&E system happen to be able to handle when they're at college and they come back with a concern about their ongoing peanut daily dosing? So those are our main areas of discussion, and they won't be sorted out in the next 12 months, but it's something to revisit in future, and a real need to collect data on what actually happens live in future.
Thank you. That's very, very illuminating. Super interesting discussions must have been. So, how did you handle conflicts of interest in the process?
Yeah, it's really important. So we reported conflicts of interest when we were first involving the voting panel, and then of course the people who were involved in coordinating the study initially, and then again we refreshed all of the outcome when we were doing the workshops at the end, in line with the Cochrane principles. I mean, it's not a systematic review, so it's slightly different with the voting board and then the people involved in running the study. But we had a third of people who had any direct benefits from Aimmune, the manufacturer and producer of Palforzia. So it was within the guidance for what Cochrane said, and it's all reported on the publication itself, for those with more interest. It obviously has to strike a balance, right? Because this is an emerging therapy. We need to have people who are aware and used to seeing the turnover of that in emerging practice. So you need people involved in the research. You need people who are involved in where it may be operating and coming out, being implemented in centres that are able or likely to be able to offer it. So we have to have a balance and be fully aware of the conflicts and the benefits of having early experience with a product as well.
Thank you. One last question is, what sort of implications do you think this new guidance has for other forms of food immunotherapy using natural foods or other products?
Yeah, it really shows that every single part of the allergy service has to think about capacity. And it's very difficult to remove that entirely when you're trying to do the right thing for one individual child or young person. So we have to think about how many visits are really necessary to offer these types of treatments. So oral real food immunotherapy is exciting in that it removes the drug cost and the difficulties with procurement. And if you're having a pathway where you need to step down or you have a reaction or some time out that you need further doses at one level. So having it as a freely available food is certainly better. But actually that cost isn't at the moment taken on by the department anyway. And you still end up with oral food immunotherapy and the necessity to come in for regular updosing. You still have to take that as part of service provision, so it's still difficult. And it does raise the question about, well, should we be considering other forms than other routes? So there's the peanut patch, the epicutaneous therapy, which is quite far down, having its last set of randomized trials to be able to assure from an efficacy point of view that it's going to be granted FDA license in America and also the European licensing. And then there's a question about whether other routes such as sublingual, which need a lot more work, whether or not sublingual might be a way of reducing the number of visits as well. So those two other routes are also going to be important to watch for in the developments in future.
John Mast, thank you very much for a really interesting interview.